Hello, guys. In this discussion, we're going to look at chronic leukemia and myeloproliferative disorders. So, our main focus is chronic leukemia, but because from our discussion of acute leukemia, there will be something that will be expected to be mentioned under chronic leukemia. Now, that disorder that will be expected to be mentioned under chronic leukemia, ideally it is discussed under myeloproliferative disorders. That's the reason why I've put this as chronic leukemia versus myeloproliferative disorders, so that we can make that perfect correlation for even a better understanding of the topic. Unfortunately, I had no time to create some sort of a PowerPoint kind of presentation, but because I just have some time to maybe create a discussion to make it so that we have the part 1 on acute and part 2 on chronic, for people to have something to perhaps use for revision purposes. Okay, so now when we talk of chronic leukemia, the key message that I want you to have is that chronic leukemia is the neoplastic proliferation of mature cells. I'll end there first because I don't want to specify at the moment. With that being said, we can look back to our previous topic where we talked of acute leukemia. Remember that under acute leukemia, we said it is a neoplastic proliferation of immature precursor cells. Yeah, we said it is a neoplastic proliferation of the precursor cells, either of the myeloid lineage or the lymphoid lineage. And we said these precursor cells are immature cells which are referred to as the blast cells, which are still undergoing, or rather which are still supposed to undergo a process of maturation for them to become mature blood cells. Now, when we talk of chronic leukemia, this one looks at a neoplastic proliferation of mature cells. Now, these mature cells again can be of the lymphoid lineage and the myeloid lineage. Now, when you talk of chronic leukemia, this one refers to the neoplastic proliferation of mature cells of the lymphoid lineage. Neoplastic proliferation of mature cells of the lymphoid lineage. No wonder you find that in some literature they would define chronic leukemia as a neoplastic proliferation of mature lymphocytes, and that would be of either T cell origin or B cell origin. When we talk of myeloproliferative disorders, these are disorders that are characterized by the neoplastic proliferation of mature cells of the myeloid lineage, and the type will be dependent on the dominant produced cell of that myeloid lineage cell type. I'll talk more on that towards the end. So we'll put myeloproliferative disorders towards the end to make that comparison, because it is under myeloproliferative disorder where we will talk about chronic myeloid leukemia. So just under chronic leukemia, our main focus will be on the chronic leukemias of the lymphoid lineage. I hope now you understand why I had to bring this up. You may think I'm taking much time to describe these two, but this is the area of importance. Once you understand this area, where chronic leukemia talks about neoplastic proliferation of mature cells of the lymphoid lineage, and myeloproliferative disorder refers to a neoplastic proliferation of mature cells of the myeloid lineage, and that the type will be dependent on the dominant produced cell of that myeloid lineage. Then the rest becomes easy to follow. It's just a matter of connecting things. So when we pick chronic leukemias separately, let's hear what there is to know about them. So, like I've already mentioned, chronic leukemia is a neoplastic proliferation of mature lymphocytes, which could either be of the B cell type or the T cell type. So, this disorder will be characterized by a raised white blood cell count, okay, and it is usually insidious in onset and common in adults. Okay. Now, because we are saying the chronic leukemia can either be of the T cell type or the B cell type, which is a similar pattern with what we did in acute leukemia. Now, your area of understanding at this point should be what types of chronic leukemia arise from the B cell type and what type of chronic leukemias arise from the T cell type. And that is where we'll briefly talk about some types and maybe a bit of details so that you have that general understanding. So, on the B cell type of chronic leukemias, which I'm still emphasizing to say it is a neoplastic proliferation of mature lymphocytes. Yeah? So the B cell type of chronic leukemias, we have chronic lymphocytic leukemia. Yeah? We have chronic lymphocytic leukemia on the B cell type. And this one, it is defined as a neoplastic proliferation of naive B cells. Keyword, naive B cells. A neoplastic proliferation of naive B cells. Now, how would we be able to identify these mature naive B cells in chronic lymphocytic leukemia? These will express surface markers CD5 and CD20. Now, if you remember under acute leukemias, when we were talking about the acute lymphocytic leukemias, we mentioned to say they can be of the B cell type or the T cell type. And we said we use surface markers to differentiate whether it's of the B cell type or the T cell type. That was under acute leukemias. And the surface markers we talked of under the B cell acute lymphocytic leukemia were CD10, CD19, and CD20. Remember that? Then on the T cell acute lymphocytic leukemia, we said the surface markers are CD2 to 8, which would be CD2, CD3, CD4, CD5, and to 8. Yeah? Now, why am I bringing this up? Because the atypical finding here is that we are having CD5 as a surface marker of a B cell type, of which we normally expect to find CD5 in the T cell type of leukemia. Okay, I thought that might be worth mentioning. So, chronic lymphocytic leukemia is a neoplastic proliferation of naive B cells. It will be characterized with the surface markers CD5 and CD20. Okay, then from there, the other area that you need to understand is that when you do a blood smear, the typical finding you see is that there will be the presence of these same naive lymphocytes and smudge cells. Now, smudge cells, unfortunately, no any image to illustrate, but it will be like this cell that has been crushed, and it's more of like showing its structure, but in a crushed kind of um, frame or rather structure. Okay, that's the smudge cell that you'd find. That's it about chronic lymphocytic leukemia briefly. Now, when it comes to how it might present, ideally, most leukemias of the lymphoid origin, they preferably go to the lymph node. So someone can present with generalized lymphadenopathy, and because of this lymphadenopathy, this would also be referred to as small lymphocytic lymphoma because of the aggregation within lymph nodes. Okay, then complications that you might expect from CLL is that because these are naive B cells that are proliferating uncontrollably, irreversibly, and uncoordinated, you expect that they won't carry out their proper function of antibody production. So a typical finding in this patient would be hypogammaglobulinemia. Yeah, and the other finding you'd find, because these are naive lymphocytes that are abnormally proliferating, is that if they tend to produce a number of antibodies, there's that propensity of autoimmunity, where you might have autoimmune hemolytic anemia because they are not even well trained to carry out their function. I like remembering this by using the word naive. When an individual is said to be naive, what do you expect from them in terms of experience? They will lack experience, right? So now I'll ask myself to say, what does a B cell do? And if it's naive, what do I expect to be the outcome in those things that it does? And that's how I come up with things like hypogammaglobulinemia, where it may not produce sufficient antibodies, and autoimmunity, where if it even produces antibodies, they may not be, selective enough that they might even, coat normal cells of our body. Autoimmune hemolytic anemia would come in. Okay, then the other thing that would come in as a result of the chronic lymphocytic leukemia is actually, since there is this lymphadenopathy associated with it, later on there could be further activation of these B cells within the lymph nodes that would lead to massive growth of these lymph nodes and splenomegaly and all that, and this would actually later on transform into diffuse large B cell lymphoma. Okay, so basically that's something that is worth mentioning under the chronic lymphocytic leukemia. The other type of leukemia, a chronic leukemia under the B cell lineage of the lymphoid lineage, is hairy cell leukemia. I want you to continue following me on this one. So we are still on chronic leukemia, which is of the neoplastic proliferation of the mature cells of the lymphoid lineage. Now we are talking of types under the B cell lymphocytes, of which our first one was chronic lymphocytic leukemia, where we say it is neoplastic proliferation of naive B cells. Now, hairy cell leukemia, it is also a type of chronic leukemia of the B cell type, and it is a neoplastic proliferation of mature B cells. You see the difference there? This one, in hairy cell leukemia, the neoplastic proliferation is of mature B cells. And in terms of some features that we may mention, the term hairy itself in the name of hairy cell leukemia comes from these cytoplasmic projections that come out of the cytoplasm, which are finger-like projections resembling hair. Okay, and these are referred to as hairy cytoplasmic processes, and that's where that hairy cell leukemia name basically originates from. Okay, and these cells will test positive for titrate resistant acid phosphatase, the trap. I use the mnemonic trap to help me remember titrate resistant acid phosphatase. Okay, when we talk of features, when it comes to features, ideally the common features that will be there will be splenomegaly. Okay, and it is worth mentioning that this splenomegaly usually involves the red pulp. It is worth mentioning again because it is not ordinary. We expect if the splenomegaly involving the lymphocytes, it should be affecting the white pulp where we find the lymphocytes. But in this case, the splenomegaly is as a result of the red pulp. Okay. Other features that you find are things such as dry tap on bone marrow aspiration and absence of lymphadenopathy. Okay. Now, those are the types that we've talked about so far under the B cell type of chronic leukemia. When we go to the other hand of chronic leukemia of the T cell type, we have what we call adult T cell leukemia lymphoma. Okay, the only special thing worth knowing about this is that one, it is the neoplastic proliferation of mature CD4 positive cells. We are on the T cell side now, you get? From there, the other thing that is worth knowing is that adult T cell leukemia lymphoma is usually associated with the human T cell leukocyte virus type 1. Yeah, it is associated with the human T cell virus type 1. Okay, and it is common mainly in the Caribbeans and Japan. Those are some points that are worth mentioning under the ATLL. Then when it comes to the presentation, it is worth knowing that in ATLL you find the typically a patient will present with rash. Apart from the rash, there will be lymphadenopathy because of that propensity of lymphocytes, going into the lymph node, and it's also said that there's that a propensity of going to the skin. Okay, so rash and lymphadenopathy. Okay, hepatosplenomegaly is one of the features you would find, and one of the features that is worth mentioning is lytic bone lesions with hypercalcemia. Why? Because this might also be mistaken with multiple myeloma, which will also present with lytic bone lesions and hypercalcemia. Okay, but the presence of rash and hepatosplenomegaly and lymphadenopathy should give you a thought to first try and rule out adult T cell leukemia lymphoma before thinking of multiple myeloma. Okay, so that's it about ATLL in a few details. The other one that is worth mentioning under the T cell type of chronic leukemia is mycosis fungoides. So this is also a neoplastic proliferation of mature CD4 T cells. Okay, this one specifically presents with infiltration of the skin, where someone would present with plaques, nodules or rash on the skin. And there's a characteristic term they use to refer to the presence of aggregated neoplastic T cells in the epidermis due to this condition, and they refer to it as Poirier microabscesses. This might also be worth mentioning. Okay. Apart from that, these T cells can also spread to the blood, and this will bring about a syndrome they refer to as Caesar syndrome. Worth mentioning related to this syndrome is that these T cells will have a nuclei which they refer to as a cerebriform nuclei, where the nuclei appears to be like having robes that give it like that brain-like appearance of those robes that you see on the brain, cerebriform nuclei. Okay, so that's it about the other type. With that being mentioned, the other half of this presentation, which I expect to do maybe in the next 6 minutes, we'll talk about myeloproliferative disorders. Okay. So far, our understanding is that we now know to say chronic leukemia refers to neoplastic proliferation of mature lymphocytes. Keyword, mature lymphocytes. And this chronic leukemia could either be of the T cell type or the B cell type. Of the T cell type, we have adult T cell leukemia lymphoma and mycosis fungoides, for examples. Of the B cell type, we have chronic lymphocytic leukemia, which is neoplastic proliferation of naive B cells, and we also have hairy cell leukemia, which is neoplastic proliferation of mature B cells. I've put in this description to differentiate the two under the B cell type of chronic leukemia. Okay, so now we go to the other half of neoplastic proliferation of mature cells of the myeloid lineage, which are termed as myeloproliferative disorders. So generally speaking, the take-home message here is that chronic myeloid leukemia is a form of leukemia that exists under a group of disorders that are termed as myeloproliferative disorders. And it is the main reason why I brought this discussion under the talk of chronic leukemia. Okay, so now myeloproliferative disorders, I've already defined them. They are neoplastic proliferation of mature cells of the myeloid lineage. Keyword, mature cells. And these disorders, just like the chronic leukemia, will also be characterized with a raised white cell count, with a left side shift. Okay, with that being said, it is also worth knowing to say these disorders will usually present in late adulthood, and the disorders will be differentiated, or rather will be classified based on the dominant cell of that myeloid lineage that is produced. Okay, the take-home message on this point is that in myeloproliferative disorders, all myeloid cell lineages are increased, but there is a predominancy of a particular cell type of the myeloid lineage, and it is that dominantly produced cell type of the myeloid lineage that gives the name of the disorder. For instance, if the predominantly produced cells are the erythrocytes, we will call this polycythemia vera. If the dominant cells produced in this neoplastic proliferation of mature cells of the myeloid lineage is the megakaryoblast, we'll call this myelofibrosis. If it's the platelets, we'll call this essential thrombocythemia. If it's the granulocytes, we'll call this chronic myeloid leukemia. So chronic myeloid leukemia, let me start with the same one. Chronic myeloid leukemia is a neoplastic proliferation of mature cells of the myeloid lineage, especially the granulocytes. Things to know about chronic myeloid leukemia, like I had even mentioned under acute leukemia, is that it is associated with the Philadelphia chromosome, the translocation 922. And this translocation 922 brings about this pathology basically by increasing tyrosine kinase activity via the fusion of the BCR-ABL genes. Okay. So this fusion leads to increased tyrosine kinase activity, which drives this process now of chronic myeloid leukemia. Okay. Other things that are worth mentioning on this disorder is that it will be also characterized with basophilia. Okay. When we come to polycythemia rubra vera, the definition will be the same. The only difference will be this is now especially erythrocytes, neoplastic proliferation of mature cells of the myeloid lineage, especially the erythrocytes, and we are calling this polycythemia rubra vera. The important thing to know here is that with increased erythrocytes in blood, there will be increased viscosity, and most of the problems that are associated with this disorder will be as a result of that increased viscosity. Okay, the headaches, the blurred vision, the thrombus formation because of increased viscosity, hypercoagulable state. Okay, and the other things such as flushing due to congestion of vessels, all such things. Okay, and maybe worth mentioning again is that these clients can present with itching after bathing, and the itching after bathing will be as a result of increased mast cell expression that it tends to degranulate when water when water is poured on the body. Okay, with that being mentioned, I would like to believe we have at least an understanding of polycythemia rubra vera as a type of myeloproliferative disorder. But again, you have to remember to differentiate reactive polycythemia from polycythemia rubra vera. With that being said, polycythemia rubra vera is associated with the JAK2 kinase mutation. Wow, reactive polycythemia, this is usually due to decreased oxygen levels, where there will be a compensatory mechanism that tries to replace the decreased that tries to maintain perfusion, okay, by increasing the process of hemopoiesis. Already there, as intellect medicals, I expect that we have already started connecting to say that in a reactive polycythemia there will be one decreased oxygen saturation to drive that compensatory mechanism, and part of what will drive that compensatory mechanism to increase hemopoiesis to try and compensate for the hypoxemic state and maintain oxygenation of tissues will be increase in erythropoietin, which will help to drive that process. And these are the things that will help to differentiate polycythemia rubra vera from reactive polycythemia. because in polycythemia rubra vera, the driving factor, we've already said, it associated with JAK2 kinase mutation, and there will also be normal oxygen saturation, and erythropoietin will actually be decreased in this disorder because of the increased production sends some sort of a negative feedback on erythropoietin production. Okay, I believe that has been understood there. A general understanding you may have to have at the back of the mind is what sort of disorders or other conditions that would bring in this reactive polycythemia. So think of lung diseases that can impair oxygenation, yeah, or rather ventilation, lung conditions that can affect ventilation. Think of cardiovascular disorders that affect, the thing of oxygenation. I like to categorize these as anything that has the capacity to cause ventilation perfusion mismatch would lead to hypoxemia, and such a compensatory mechanism would come in. Okay, so lung diseases, cardiovascular diseases, things that can also increase erythropoietin production would be malignancies. Commonly, renal cell carcinoma would produce abnormal amounts of erythropoietin. Okay, and that would lead to increased hemopoiesis and raised red blood cell mass within the blood. Okay, so there now I believe we have an understanding on polycythemia rubra vera and how to differentiate it from reactive polycythemia, and we have a general understanding on chronic myeloid leukemia. The other ones that are worth mentioning, just to quickly revise them here under myeloproliferative disorders, is essential thrombocythemia. Okay, essential thrombocythemia, this is same definition, but in this state there is more of thrombocytes being produced. Okay, there is more of thrombocytes being produced. Okay, then in terms of expected features, think of those platelets that are overproduced. If they are overreactive, they could lead to thrombus formation. If they are defective, they could lead to bleeding, and that would be the usual presentation. Okay, and this is also driven by the JAK2 kinase mutation. In myelofibrosis, this is where you have a dominance in the production of megakaryocytes. Okay, in myelofibrosis, this is where you have that dominance in the production of megakaryocytes, the platelets. I mean the what's this? Yeah, so of the megakaryocytes, you pardon me on that one. I must be tired now, so let me just try to conclude this first. So, in myelofibrosis, this is where you have a neoplastic proliferation of mature myeloid cells, especially the megakaryocytes. Now, in myelofibrosis, when there is it is one thing that you need to understand is that it's also associated with the JAK2 kinase mutation, and once there is this neoplastic proliferation process taking place, one of the end results that occurs is that as megakaryocytes are increasing in number, they also increase the production of platelet derived growth factor, and this platelet derived growth factor will end up leading to myelofibrosis. Okay, that is something that is important to know about myelofibrosis. Okay, so now that we have that general understanding of myeloproliferative disorders, generally speaking, or rather briefly describing them, it is worth mentioning also to say myeloproliferative Myeloproliferative disorders have common complications associated with the increased cell turnover due to increased production. And these are complications such as hyperuricemia, gout. Okay, no wonder when you see in the management there is the aspect of giving drugs such as allopurinol. Just get to know that this is the reason why it's been given, due to increased cell turnover and activation of the purine degradation pathway that subsequently leads to hyperuricemia and the gout. So you're trying to prevent such from happening. Okay, the other thing worth knowing is that generally under before I actually proceed, it is important to know that under myeloproliferative disorders, essential thrombocythemia doesn't have a risk for hyperuricemia and gout because platelets are not entirely cells. Remember, they are just cytoplasmic particles. So there is no such thing as nuclear degradation and all that when it comes to platelet. So it is the exception. The other common complication in these disorders is that they can progress to myelofibrosis. Like I had already mentioned in myelofibrosis, where there's increased production of the platelet-derived growth factor that drives the process of fibrosis, leading to myelofibrosis. Okay. The other complication that you'd expect in these disorders is that it can actually transform, myeloproliferative disorders can transform into acute leukemia. And when they transform into acute leukemia, they are most likely to transform into acute myeloid leukemia than acute lymphocytic leukemia. In other words, we are saying there is a higher incidence of transforming into acute myeloid leukemia and lower incidence of progressing or transforming to acute lymphocytic leukemia. Okay, so generally speaking, that was it. I would like to just close this part by giving you a concluding statement of both acute leukemias, chronic leukemias, and myeloproliferative disorders. In the acute leukemia presentation, when you think acute leukemia, think of neoplastic proliferation of precursor cells, the immature blast cells, which can be of the myeloid lineage or the lymphoid lineage. When you think of chronic leukemia, think of the neoplastic proliferation of mature lymphocytes, which can be of the B cell type or the T cell type. When you think of myeloproliferative disorders, think of the neoplastic proliferation of mature cells of the myeloid lineage, and the type will be determined by the dominant myeloid cell type that is being produced, either red blood cell, platelet, or rather granulocytes. I would like to end this discussion there. I hope you find this useful. Thank you for your time. Stay blessed.